Assalamu alaikum. We're starting off with the cognitive behavioral therapy. We're starting off with the psychological therapy or a psychological treatment for schizophrenia, psychological treatment or a psychological way through which we could either treat or manage schizophrenia. Now, as we speak about our syllabus, since it's almost like a ritual for me. We're starting off with this part, the psychological therapy, where we discuss cognitive behavioral therapy that would include a study, right? Which, for example, could be Sensky et al. Study. The Cambridge is giving us an option that we need to, as a teacher, I need to teach students cognitive behavioral therapy, including a study. And then the Cambridge is hinting us on using the study by Sensky et al., although we have an option of studying any other example study too. But since we're studying in a group and I'd want everyone, all of us to be on the same page. And this study that was conducted by Sensky et al., which is, of course, not a key study, this is an example study, it's very clearly mentioned over here, is a part of our course book as well. So we'd start off with this one, this particular bullet. So a descriptive question that you could get on this is describe the psychological therapy for schizophrenia. Or you could get a question that might say, describe the biological treatments and psychological therapy. In that case, write worth 3 marks for this one and write worth 3 marks for this one. I think I've mentioned it earlier as well. You do get descriptive questions that pick up content from 2 bullets. So CBT, cognitive behavioral therapy. Let's connect this. Let's go back to our base, connect this with the basics and talk about schizophrenia. Schizophrenia, like I had said, like we all by now know, is a psychotic disorder. What does the word psychotic disorder mean? When you lose your grip on reality. Popular symptoms of schizophrenia are, if we talk about popular positive symptoms, we have hallucinations, we have delusions. If we speak about popular negative symptoms, we have lack of motivation, which is also referred to as avolition, or we have individuals because of a thought disorder leading to incoherent, poor speech. Now, we know what schizophrenia is. We have reminded ourselves of the popular positive and negative symptoms of schizophrenia. Let's talk about CBT. What does CBT over here stand for? CBT, as you see it written at the top, written at the top, it says cognitive behavioral therapy. Now, when we speak about cognitive behavioral therapy, let's focus on these words one by one. Your cognitions are your thoughts. Your distorted thoughts are perhaps the reason that are leading to you experiencing the symptoms that you're experiencing. So it could be, if you recall, Frith was referring to these thoughts as uh, a faulty mental process. We could refer to them as irrational thoughts. So it's your irrational, maladaptive, illogical, distorted thoughts that are perhaps the reason that are leading to this particular disorder. Now, let me remind you again, each of the treatments that you study is connected to a particular explanation. Now, since we're discussing psychological therapy, or since we're discussing the cognitive behavioral therapy, this has its roots linked to the cognitive explanation of schizophrenia. Having said that, CBT is cognitive behavioral therapy, where C is cognitions. The idea is that your irrational, illogical, maladaptive thoughts are what lead to a particular type of behavior, which is exhibited through positive symptoms and in some cases negative symptoms too. How does CBT work? CBT works on the principles that our thoughts, our feeling, and behaviors are connected. Our thoughts, our feelings, and our behavior are connected. And I'd explain you this diagram that we have over here that would help you understand this better. So, uh, since CBT works on the principles that our thoughts, our feelings, and our behavior are connected, if we somehow learn to challenge those irrational, illogical thoughts, we would be able to rectify our behavior. But for us to be able to challenge those illogical thoughts, we need to first be able to identify them. I'll say it again in Urdu, the same thing. Cognitive behavioral therapy होती क्या है? कॉग्निटिव बिहेवियरल थेरेपी जब हम आ, अपनी कॉग्निशंस को, अपने थॉट प्रोसेस को चेंज करते हैं, को चैलेंज करते हैं। पहले हम आइडेंटिफाई करेंगे, फिर हम उन्हें चैलेंज कर पाएंगे, फिर हम उन्हें रेक्टिफाई करेंगे। ठीक है, पहले पता तो चले कि हमारी वो इलॉजिकल थॉट्स हैं क्या। So what I said was, it's pretty essential for us to be able to identify those illogical thoughts. Of course, if we're talking about people who are potentially schizophrenic, and if they're schizophrenic, there's a likelihood of them hallucinating or or under delusion, or as you all refer to as delulu. So, cognitive behavioral therapy. An example, for instance, if I give you an example over here, if there's a patient who hears a voice that says you're worthless, right? Let's just say for a moment, if I'm a patient and I hear a voice that says you're worthless, how does CBT help me? CBT could help me question this. Remember when I'd use the word challenge? Could this voice that I'm hearing be because of my illness speaking? Is it my inner thought that I'm misconceiving? That is it my inner thought that I'm not being able to not being able to correctly interpret? Is it my inner thought that I feel is an outside voice that is speaking to me? All of these are some examples that I'm trying to use to help you understand how we could challenge these irrational thoughts. So instead of believing that I'm worthless just because I hear a voice that says I'm worthless, I could challenge this irrational, maladaptive, distorted thought. And I could give myself a benefit of doubt by questioning that it could probably be, or it could probably be because of my illness. It could probably be a symptom of schizophrenia and not what reality is like. How does CBT work? If we speak about how CBT works, number one, engagement and trust. So the therapist tries building a rapport with the patient, because the patient, of course, if the patient is experiencing persecuted delusion, the patient might feel suspicious. The patient might not even want to trust the therapist here. One. Number two, we could try normalizing this by, of course, there's a negative stigma that is attached to these mental illnesses. You could explain the patient that these thoughts that they're experiencing, they're not, there are many other people who experience these thoughts. This would help them feel better. You're trying to reduce the stigma that is attached to this. You could help them identify. Now, this is an important role, or this is an important part over here. You could help them identify those irrational thoughts. How is it that you'd be able to identify them? How is it that you would be able to help them identify these thoughts? You could, I mean, if someone has the thought that the government is controlling, if someone feels or believes that the government is controlling their thoughts, try talking sense into them, try explaining them how this particular thought, how this particular delusion is bizarre, and how the government doesn't really have anything to do with the way you think or you believe. And then we could move on towards reality testing. The therapist and the patient, they could look for evidence together. They could be like, the therapist could be like, okay, fine. If it is this way, let's together work for let's together look for evidence. If we're both able to, or if either of us is able to find evidence that supports the idea that the government is actually up to something, that means fine, we'd end up agreeing to it. But what proof do you have at this point that the government is controlling your thoughts, or the government is spying on you, or the government has anything to do with you? Next, we could work towards developing coping strategies. And how is it that we can develop coping strategies? You could help the patient with distraction techniques. You could help the patient with relaxation techniques. You could help the patient through positive self-talk. If I may give you another example, if If I'm a patient and I think I feel there are voices that speak to me, there are voices that command me, that order me, that tell me what to do, and I walk up to a therapist. So I'm the patient now, and now I'm walking up to a therapist, and therapist goes like, okay, let's do one thing. Let's figure out what actually is wrong. And if you actually think there's a voice that speaks to you or converses with you, let's keep a voice recorder in your pocket. Just keep the voice recorder with you always. And if there's in reality an external voice that communicates with you, we'd have that recorded too. So that's just one way. I was just trying to give you a couple of examples through which I was trying to help you understand the different ways, the different techniques that an experiment that a therapist could use. Now, when and as we speak about when and as we speak about cognitive behavioral therapy, remember I'd initially said your thoughts are connected to the way you feel, and the way you feel is connected to the way you behave, right? The way you think is connected to the way you feel, and the way you feel is connected to the way you behave. So this is essentially what I'm referring to over here. For instance, if I may give you an example, if someone with schizophrenia thinks, we're starting with the red circle here, if someone, I don't know if I can zoom this. Okay, I think this works. Yeah, so I just remove all the extras from here. So yeah, if I'm someone, uh, yeah, if we start off with this first one, the thoughts part, if someone with schizophrenia thinks that the government is controlling them, that creates a very strong feeling of fear, right? They might feel fearful. And moving on to the next step, that is the feelings part, this feeling could lead to anxiousness, this feeling could lead to anxiety, which might consequently result in the person behaving in a particular manner by avoiding contact with people. So it eventually turns into a vicious cycle. It's the way you think leading to the way you feel, and the way you feel leads to the way you behave, which again reconfirms your, and since the patient starts avoiding people, they tend to believe that it is true. The avoidance behavior might make the person paranoid. The avoidance behavior might further reconfirm the initial thought that they had, which it wouldn't be wrong if I use the word, it would end up being working like a vicious cycle here. So, cognitive behavioral therapy, basic tips. According to cognitive behavioral therapy, you change the way someone thinks, which changes the way they feel, which leads to a change in the way they behave. So, cognitive behavioral therapy is an approach to the treatment of mental health disorders, which incorporates principles of both the cognitive and behavioral approaches to psychology. Now, you've studied the cognitive approach, and if you recall, uh, if you recall, okay, I will have to. So, yeah, someone's mic got unmuted. Where was I? I lost track. Yeah, if you recall, right at the beginning, before we had even started with the first unit, that is schizophrenia, I tried explaining you the different models that we would need to know and understand when it comes to learning clinical psychology. Remember, your cognitive approach was focusing on your irrational thoughts, and the behaviorist approach was focusing on the experiences that you have. So when I use the word cognitive behavioral therapy, this is both working together. Now, this particular therapy, that is cognitive behavioral therapy, this departs from the behaviorist strict focus on observable behavior in order to recognize the influence of invisible cognitive processes on learning. So, if I put it in a simple manner, the behaviorist approach, since this focuses on the experiences you have, you since you're restricting yourself to the experiences an individual have, and the experiences an individual have, they're observable. On the other hand, if you speak about your cognitions, that is your thoughts, they aren't observable through human naked eye. So we're talking about a combination of your cognitive approach and the behaviorist approach. So a simple way to put it, for the third time now, you change the way someone thinks, which eventually leads to a change in their behavior. CBT is a talking therapy designed to help people change through recognizing thoughts which underlie their behavior. So you need to recognize those thoughts. You need to help your patient identify those irrational, illogical, distorted, maladaptive thoughts. Help them identify. It has been identified as promising treatment for reducing the distress, disability, and hospitalization that occurs in individuals with schizophrenia who do not respond well to antipsychotic medication. Now, CBT is again an alternative technique that is used, or at times you use CBT along with antipsychotics as well. There are some patients which we had discussed yesterday in our previous lesson in the when we were discussing the biological treatments to schizophrenia, when I had said there are some patients that are treatment resistant because not every medicine works for everyone, and not every medicine works for everyone in the same manner. So for patients for whom antipsychotics might not be the best of option, be it typical or atypical antipsychotics, for patients who are treatment resistant, CBT could be a safer option for them. Now, before I get started with this example study that was conducted by Sensky et al., I would want us to have a spend a couple of minutes discussing the comparison, or knowing and understanding the comparison between biological treatments and cognitive treatments. To begin with, if we speak about biological treatment, it would be as simple as popping in a pill. And if you're popping in a pill, that's easy, that's convenient. You just pop a pill, you drink water with it or any other liquid, and you through. And on the other hand, if we speak about the cognitive treatments, they're very demanding. They require a lot of motivation. They uh, require a lot of involvement from the patient. I mean, uh, so yeah, this is a happy face, this is a sad face. I hope you guys don't get confused with the color. So I'll turn the smileys green, just turning the smileys green here. And that's it. The first point. So yeah, biological treatments, they're seen to be more convenient. They're seen to be more effective. They seem to have uh, they are less time consuming, right? One, they're convenient. Number two, biological treatments are less time consuming. Whereas when you talk about cognitive treatments, they're more time consuming. At times, you end up spending months and months of going through your therapy sessions, and which of course requires a lot of motivation, requires a lot of dedication, requires a lot of consistency and your personal involvement into it. If you move on to the third point that works in favor of the cognitive treatments, because if you put them in a simple manner, they're talking therapies and they do not have any side effect. Yes, they take a lot of time. Yes, they're very demanding, but there's no side effect when it comes to cognitive treatment. And in on the other hand, if we speak about biological treatments have their side effects. Every medicine has its side effects, and some of the medicines might have more dangerous side effects as compared to the rest. But nonetheless, when it comes to medication, when it comes to taking drugs, it they always involve side effects. The fourth point, for cognitive treatment, like I mentioned earlier, you require a lot of motivation. Again, the first and the second and the fourth point, under the heading of cognitive treatment, they're all intertwined. Uh, they're pretty much in line with each other, and pretty much they revolve around the same idea. So an individual, the bottom line, an individual needs to be highly motivated and disciplined and consistent to get through cognitive treatment as compared to the biological treatment. Even if you're not very motivated, popping in a pill isn't really very difficult. So taking this ahead, and let's move on and talk about this study that was conducted by Sensky et al., which is an example study. And to remind you, for an example study, the syllabus says you don't need to trust what I say. Go Google this, just type down 990 A-level psychology syllabus. And I don't exactly remember what page, but I'm sure you would. Uh, I've shown that slide to you earlier. Just go and figure out, just go and read. The syllabus very clearly says that you would not get specific questions that demand details on an example study, right? So for instance, even when I have put down numbers over here to help you understand this better. Yes, the core idea behind the study that was conducted by Sensky et al. Uh, is something you should know. You should have a basic idea on how, on what the aim was, what the procedure was like, and what the findings were like from this particular study. Yes, you should know enough to be able to write an answer to a 6-mark question if you get a particular question on the bullet that has cognitive treatments as cognitive methods or cognitive treatments for schizophrenia. Just know enough, such as the aim, the procedure, and the findings. Yes, if you are keeping in mind the evaluation question that follows the descriptive question, you would have to know a bit more. For instance, if you plan on evaluating the content in a particular, under a particular bullet through research methods or methodology, in that case, you could mention the amount of patients. Like, for instance, in this particular study, it says there were 90 patients, which is not a very big number. The age range of the patient varied from 16 to 60 years, which is pretty decent. This study was specifically conducted on individuals who were diagnosed as treatment resistant for schizophrenia. So, question that rises over here is, would this apply to everyone? And would this apply to everyone? Everyone who is, would it apply to the individuals who are not treatment resistant? Uh, yeah, there was an independent groups design used, so they could be participant variables that are there. There was the participants, they were allocated to conditions randomly, which again works in favor of this particular study. So if you're planning on using methodological aspects to be able to evaluate, then you need to know more. If not, the examiner says they won't ask you a specific question to the point. Yeah, they won't ask you a specific question. So let's move on and start off with the study that was conducted by Sensky et al. As an example study that helps us understand cognitive behavioral therapy as a treatment and a management technique for schizophrenia. Sensky et al. In the year 2000 carried a randomized control trial. What does the word randomized control trial over here mean when we use, or as we use the word randomized control trial? It's more like flipping a coin, right? You're not biased. You're not biased because you're not choosing which individual would be put into what group. Everyone has a fair opportunity because you're randomly allocating participants, which of course adds on to the credibility and the accuracy of your findings, adds on to objectivity of your research as well. So Sensky et al. Carried a randomized controlled trial to compare the effectiveness of cognitive behavioral therapy with a control group who engaged in befriending. So there are two groups that we're referring to over here, since this was an independent measures design or independent groups design. The first group, we're referring to that as the CBT group, and the second group, we're referring to that as the befriending group here. CBT is CBT, where you help the patient, where you speak to the patient, you help them identify and then challenge and further rectify their problems. Problem in the sense that they're irrational thoughts. Whereas if we speak about this befriending session group, befriending sessions included informal one-to-one discussions about hobbies, sports, or current affairs. There were 90 patients, age ranged between 16 to 60 years, with a diagnosis of treatment resistant schizophrenia from 5 clinical services. They received a mean average of 19 sessions of cognitive behavioral therapy or befriending over the treatment period. They were randomly allocated to either treatment condition or the control condition, that is the befriending condition, making this an independent groups design. Each intervention was delivered by two experienced nurses. Since we're talking about the nurses being experienced, that again adds on to the value and credibility of this research. Or you could also say the researchers were careful about catering to the ethical guidelines. Now, taking this further, patients were recruited if they fitted the following criteria. And what was the criteria here? They were aged between 16 to 60 years. Anywhere in between, they had a diagnosis of schizophrenia according to both the ICD and the DSM, that is the Diagnostic and Statistical Manual for Mental Disorders. They had symptoms that had persisted for at least 6 months. So, all of this reflects that there are high controls. And the better controls there are, the better position the experimenter is in to be able to figure out the cause and effect relationship. And these patients had not shown any improvement being on medication, like we had discussed earlier, the treatment resistant group. They did not abuse alcohol or drugs, so there was no substance abuse that led to them experiencing the symptoms that they were experiencing. If we hop onto the procedure here, the cognitive behavioral treatment followed distinct stages, including engaging with the patient. This is something that I initially mentioned, where we spoke about where I was telling you how the therapist tries to build a relationship or rapport with the uh, patient. So the CBT treatment followed distinct stages, including engaging with the patient and discussing the emergence of the disorder before tackling specific symptoms. For example, those with auditory hallucinations engaged in a joint critical analysis. This is something that I mentioned right at the beginning as well. Engaging in a joint critical analysis, I'd give you an example too. I mean, handing over a voice recorder to the patient and requesting the patient to keep it with him or her for a particular period of time, so that you show the patient that the voices that they're hearing are probably just from the head. So engaged in a joint critical analysis with the nurse to challenge beliefs about the nature and the origin of the voices. Patients kept voice diaries to record what they were hearing in order to generate coping strategies. Voice diaries, keeping and managing voice diaries. See, you have to be motivated, you have to be invested in this entire process, and you need to believe in it to be able to uh, help you in order to help you get through with your schizophrenic symptoms. Participants were assessed by blind rates before the start of the treatment, at treatment completion, and a 9-month follow-up. So the data was collected thrice: once before the treatment started, number two once the treatment ended, and number three at a 9-month follow-up. Participants were assessed by blind raters, and of course, if you're using the term blind raters, we're talking about how the people who were assessing were not aware of what particular condition, what particular experimental condition the participants were in. Either they had gone through the cognitive behavioral therapy, that is the experimental condition, or they were a part of the control condition, that is the befriending condition. They use a number of standardized validated assessments. So if you're using standardized validated assessments, that is again adding on value to your findings, such as the comprehensive psychiatric rating scale and the scale for assessment of negative symptoms of schizophrenia. At the follow-up stage, the CBT continued to improve in reduction of positive symptoms, whereas those in the befriending group did not. So if we have a look at this, there were 46 patients in the CBT group. I'll just pick up another color. So there were 46 patients in the CBT group. There were 44 patients in the befriending group. If you have a look at the scores from the CPRS, and CPRS is your comprehensive psychiatric rating scale. So this is what the scores look like. The CPRS scores were better for CBT patients as compared to the befriending patients, as it's very evident. And for the scale for the assessment of negative symptoms, that is the SANS total, the scores over here were the same. Now, this shows us that CBT had a long-term effect, whereas the effect the befriending group had was very short-term and did not last long. Now, this particular study that was conducted by Sensky et al., if you try scrutinizing this, they used a randomized control design, which of course adds on to the validity of the study. The assessors were blind. There was assessors were blind, which of course leads to which leads to a reduction of the amount of biasness. So assessors were blind to the treatment group they were assessing, which removes any bias they might have felt for or against the treatment. Also, since the participants were from several different clinics across the UK, the sample was probably fairly representative. Of course, you could add on the age range over here. That was between 16 to 60 years. A further strength was that the nurse in both conditions were carefully trained and monitored, which ensured that they used a standardized approach to CBT. Now, this brings the study that was conducted by Sensky et al. To an end, and this brings this unit, schizophrenia, officially to an end as well. There's a question that we had in May-June 2024, variant 3.2, and the question read, describe electroconvulsive therapy and cognitive behavioral therapy for treatment and management of schizophrenia. So see over here, the examiner expects you to write worth 3 marks for this and worth 3 marks for this one. So candidates must discuss both electroconvulsive therapy and cognitive behavioral therapy for schizophrenia, but they do not need to use the Sensky example in the syllabus. You don't need to do it. I mean, if you want to, yeah, sure. There's no, if anything, it would add on value to your answer, but you don't need to mention it. So electroconvulsive therapy, yes, we have it here. And I have shared this file with you. Yes, I've shared this file with you on your group. I would really appreciate if you could read through this and so see the examiner, what they've done is they have, remember when they said, it was right here, when they said you don't need to use this, but if you have a closer look over here, they have ended up using details from the study by Sensky et al. Oh, it's written over here as well. So I would expect you all to write an answer to this question, and hopefully, inshallah, in the next class we'd have, I would want to discuss an evaluative answer on this particular question as well. So, yeah, please start putting your pen to paper. We're done with the first unit. We're done with the first unit, that is schizophrenia. I hope this was helpful, and thank you.